Welcome to Roadmap to Residency. Hello everyone, I am Aviraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys on your journey to 250. So here we have most important sort of questions of this one, the up-down arrows, the increase, decrease, normal arrows. So these sort of questions will actually take up some of your time in the exam. And to answer these sort of questions, you need to have a clear, crisp knowledge about the topic, the mechanisms, and all the pathophysiology that is happening behind the patient. So which of the following changes in the serum lab values is most likely present in this patient? So a 30-year-old woman is evaluated for a 3-month history of progressive fatigue, decreased appetite, and a 4.5 kg weight loss. The patient has type 1 diabetes mellitus and has noticed decreased insulin requirements over this time. She has no other medical condition and does not use tobacco, alcohol, or illicit drugs. Physical examination shows generalized increased in pigmentation of the skin, especially involving the palmar creases. Measurement of serum cortisol before and after administration of exogenous ACTH shows no difference in the levels. Which of the following changes in the serum lab values is most likely present in this patient? So, what are the changes in this patient in sodium, potassium, chloride, and bicarbonate? We will come back to the question, but first, let's discuss some of the higher topics related to the adrenal gland. So talking about the adrenal gland anatomy, it has so two important layers, cortex and the medulla. Okay, now the cortex has three layers: zona glomerulosa, zona fasciculata, and zona reticularis. Okay, so GFR, and medulla has chromaffin cells. That's just basic, nothing much important. But what is important is the histology. They will ask you the defect in what are the layers, and they will just level the histology. So you just look the histology, you have this histology imprinted in your mind, right? So talking about adrenal hormonogenesis. So whenever there is ACTH hormone stimulation, it actually stimulates the cholesterol desmolase enzyme, and this cholesterol desmolase enzyme converts cholesterol to pregnenolone. Now this pregnenolone is acted upon by the 3-beta hydroxysteroid dehydrogenase and is changed into progesterone, and these pregnenolone and progesterone are changed into 17-hydroxypregnenolone and 17-hydroxyprogesterone by 17-alpha hydroxylase. Now, this enzyme is important. When we discuss about the congenital adrenal hyperplasia in another video, then these all enzymes will be of significance. But for now, just look for the flow chart, how are the hormones being produced. So the pregnenolone, progesterone, and through the 21 hydroxylation enzyme action, it is converted to 11 deoxycorticosterone, and from 11 beta hydroxylation enzyme, it is converted into corticosterone, and through aldosterone synthase, it is converted to aldosterone. So the zona glomerulosa secretes mineralocorticoids that are the aldosterone, and again the progesterone, it is actually converted to the cortisol, subsequently leading to the production of cortisone. So the zona fasciculata produces the cortisone, and the zona reticularis produces the sex steroids. So the pregnenolone is converted to 17-hydroxypregnenolone, and that is converted to dihydroepiandrosterone. And this dihydroepiandrosterone is converted to androstenedione and testosterone, and subsequently estrone and estridiol. This is just a basic flowchart. We will cover this in detail in the video of congenital adrenal hyperplasia in the future. But for now, just remember that the zona glomerulosa secretes the aldosterone, okay, the mineralocorticoids, the zona fasciculata secretes the cortisol, and the zona reticularis secretes the sex steroids. So, salt, salt, sugar, sex, okay, so 3S, salt, sugar, sex. Now, talking about the adrenal insufficiency. So, it is the inability of the adrenal glands to generate enough glucocorticoids or mineralocorticoids for the body's needs. It can be acute or it can be chronic. It can be primary, it can be secondary. The symptoms include weakness, fatigue, orthostatic hypotension, muscle aches, weight loss, GI disturbances, and sulk. cravings. The treatment is obviously the replacement therapy of the adrenal hormones. Now, talking about the difference between the primary and the secondary adrenal insufficiency. So, the primary adrenal insufficiency, as we all know from our thyroid video, primary means dysfunction on at the gland itself. Secondary means outside the gland, okay, above the gland. So, primary adrenal insufficiency is due to the adrenal problems, the defect in the adrenal glands, and the secondary adrenal insufficiency is due to the defect in the pituitary and hypothalamic conditions. So, if there's defect in the primary adrenal gland, the adrenal hormones are not being secreted, then the ACTH levels will be high. Okay, and the cortisol levels will be low, the aldosterone levels will be low, and the potassium levels will be high because aldosterone is not being secreted. You need aldosterone to excrete the potassium, right? Now, in case of secondary adrenal insufficiency, the problem is that in the pituitary and hypothalamus, so ultimately the ACTH level will be low from the above only. So from the ACTH level will be low from the pituitary and hypothalamus conditions, and that will subsequently decrease the cortisol levels, the aldosterone levels, and the potassium levels, right? Now, talking about the aldosterone mechanism of action, as we all know, aldosterone acts on the kidneys, which can lead to the sodium and water retention, and that will increase the BP. Also, the aldosterone acts on the arteries, which leads to the vasoconstriction, and it will increase the BP. And it acts on the heart, and it has a major role in the cardiac remodeling in case of heart failure. Now, talking about the action of aldosterone in the collecting duct of nephron, here we can see from the adrenal cortex, aldosterone is secreted. Now, this aldosterone acts on the ENaC channels and in the sodium potassium transporter, right? Sodium potassium, that is the ATP related, the energy mediated transport. That is sodium potassium transporter, sodium potassium pump, and the ENaC channels. So the ENaC channels is not energy dependent. So when the aldosterone acts on the ENaC channels, then the sodium directly gets reabsorbed, right? And it acts on the sodium potassium pump to just excrete the sodium outside, and for the entry of the to excrete the potassium outside, and for the entry of the sodium. So we can see when the sodium enters from this route through the ENaC channels, they have to pass into the peritubular capillary, right? And that is done by the ATP channel, the sodium potassium ATPase channel, and that is done by the excretion of the potassium, and this potassium gets excreted through these potassium channels. Also, aldosterone acts in the hydrogen channels, the S plus ATPase channels, to secrete the S plus ions. So aldosterone acts on three major things. It will resorb the sodium, and it will excrete the potassium and H plus, potassium and hydrogen ions. So if there is decrease in the aldosterone, then that will lead to high potassium, number one, that will lead to decreased sodium, and that will lead to increased H plus. The patient will go into metabolic acidosis. What are now talking about the primary adrenal insufficiency, the most common cause is autoimmune adrenalitis, and it is second most common is infection, example tuberculosis and metastatic infiltration. The clinical features include fatigue, weight loss, weakness, nausea, vomiting, abdominal pain, salt craving, and hyperpigmentation. We will talk about how hyperpigmentation actually happens. So wherever there is increase in the ACTH secretion for the secretion of the aldosterone, for the secretion of the adrenal hormones, then what happens is that it also stimulates the melanocyte stimulating hormone, and actually the pro-opiomelanocortin part just gets stimulated, and from that the melanin is produced, that will lead to hyperpigmentation. The acute adrenal crisis will lead to confusion, hypotension, and shock. So the lab findings include hyponatremia, hyperkalemia, low morning cortisols, and high ACTH. The treatment include obviously the hormone replacement therapy, glucocorticoids, and mineralocorticoids. Here we can see the palmar hyperpigmentation, the facial hyperpigmentation, the you can see in the labium or in the lips there is the hyperpigmentation in the nails. Nails are all here. What are the primary versus secondary adrenal insufficiency? So primary due to the disruption in the gland itself, disruption of the bilateral adrenal cortex. Secondary is due to the disruption of the hypothalamic pituitary axis. The possible etiologies include autoimmune adrenalitis, infection or malignancy. The secondary etiologies include chronic glucocorticoid therapy and infiltrative disease. So the cortisol is actually decreased in case of primary adrenal insufficiency. The cortisol decreased, aldosterone decreased. If these all are decreased, no negative feedback mechanism, and the ACTH will increase. But in secondary, the cortisol is decreased. Okay, the cortisol is decreased, but the aldosterone remains normal, and the ACTS is decreased because of the decrease in the hypothalamic pituitary axis. The clinical features: hypovolemia, hyperkalemia, hyponatremia, and there will be less severe symptoms like euvolemia, and there will be minimal electrolyte disturbance, or there will be no hyperpigmentation. Now, talking about the approach of the adrenal insufficiency. If the patient has symptoms or signs of adrenal insufficiency, then you just go for the um, you co-synthropin stimulation test with cortisol, or the cortisol stimulation test, and then you check the ACTS levels. When the ACTS levels are indeterminate, then you need further testing to assess the pituitary function. Now, if the basal cortisol is low and the ACTS is high, okay, then that means that there is the primary adrenal insufficiency. So after administering cortisol, okay, you check the after administering the cosyntropin, you check the cortisol and the ACTS levels. If the cortisol is low and the ACTS is high, it means the patient has primary adrenal insufficiency. If the cortisol is low and the ACTS is also low, then that means the patient has secondary or tertiary adrenal insufficiency. Now, if there is a normal response, that is the cortisol level is more than 20 uh, after 30 to 60 minutes of cosyntropin, then it is unlikely to be an adrenal insufficiency, and you need to investigate for the other causes. Now, distinguishing between the primary and central adrenal insufficiency. So if the patient has established cortisol deficiency, then you need to review or obtain, if not previously measured, the early morning plasma ACTH and serum cortisol level. Now, if the cortisol deficiency is verified, then you need to know that what is the ACTS level. Now, if the ACTS level is above the upper limit, then that is the primary adrenal insufficiency. If the ACTS level is high, then that is the primary adrenal insufficiency. Now, if the ACTS level is just in the upper half of the reference range, then that means that it is indeterminate, and you need to look for other causes like plasma aldosterone and plasma renin. And is aldosterone low with elevated renin? Yes, then primary adrenal insufficiency. Or if the aldosterone is not low with elevated renin, then that will be central adrenal insufficiency. Now, if the ACTS level remains below the lower limits of the lower half of the difference range, then that is actually a central adrenal deficiency. Talking about the pathogenesis of primary hyperaldosteronism. So in case of bilateral nodular hyperplasia, or in case of hyperfunctioning adrenal adenoma, there will be increased aldosterone. So you know what happens to when there is increased aldosterone. There will be increased potassium secretion, increased aspartate secretion, and there will be increased sodium reabsorption, right? If there is increased potassium secretion, then that will lead to hyperkalemia. If there is increased aspartate secretion, then that will lead to the metabolic alkalosis, and there is increased salt reabsorption, that will lead to the increased blood volume, leading to hypertension. And when there is hypertension, then that will decrease the renin, and that will decrease the angiotensin too. We need to shut down the RAS system, the renin angiotensin aldosterone system. Now, the hypertension will actually lead to increase in the renal blood flow and increase in the GFR, and there will be increase in the atrial natriuretic peptide. And when the GFR are increased, then there will be increased sodium excretion, and that actually how the edema. So with sodium, the water gets out, and that is how the edema is prevented, and that is called as the aldosterone escape mechanism. So the water and sodium just escaped out in presence of aldosterone by a continuous simultaneous process. Then this is called as the aldosterone escape mechanism. So again, we come back to the question: our patient has adrenal disorder. Okay, the patient has a hypoadrenalism. So what will be the defect? So the patient has fatigue and weight loss which are likely due to the primary adrenal insufficiency. Type 1 diabetes mellitus is caused by autoimmune destruction of pancreatic beta cells and is associated with an increased risk of other autoimmune endocrinopathies. Our patient had type 1 diabetes mellitus, and as a result, it will lead to the autoantibody formation against all the three zones of the adrenal cortex. Because the main effect is in the adrenal gland, exogenous ACTS administration will not increase the cortisol levels. So when we administer the ACTS, it should increase the cortisol levels if there is secondary adrenal deficiency. But if there is primary adrenal deficiency, then that will not lead to any increase in the cortisol levels because the gland is all damaged. Now, the decreased negative feedback of cortisol will lead to the increased release of ACTS. So the ACTS level will be high, and there will be melanocyte stimulating hormone increase that will lead to hyperpigmentation. Now, the affected diabetic patients often develop reduced insulin requirements because of the decreased appetite, weight loss, and increased insulin sensitivity. Do you know why? Because the glucocorticoids, they decrease the insulin sensitivity. The patient has adrenal insufficiency. All three zones are affected. The glucocorticoids are not being secreted. Then that will actually increase the insulin sensitivity, and the patient will need less amount of insulin. The hypoaldosteronism in primary adrenal insufficiency leads to decreased sodium reabsorption and decreased urinary excretion of potassium and H+. The decreased H+ excretion causes a non-anion gap metabolic acidosis with low plasma bicarbonate. Now, this leads to the compensatory chloride retention to maintain the electrical neutrality of the extracellular fluid. Now, the hypotension induced by lack of aldosterone stimulates the vasopressin release, increasing free water insufficiency, increasing free water resorption, and further exacerbating the hyponatremia. So, as a result, the patient will have hyponatremia, hyperkalemia, hyperchloremia, and non-anion gap metabolic acidosis. Remember, this hyperchloremia is the compensatory mechanism because of the metabolic acidosis. Now, talking about the last topic for this one, that is the circadian rhythm and the cortisol cycle. You can see that the cortisol release is related to our sleep cycle. It is most in the breakfast time, and it is the least in the snack time, right? Not most important, but that's you need to know that the cortisol also has a circadian rhythm. Thank you for watching. We will again back in the next one with again the super duper concept. Thank you all.